The purpose of this discussion is to understand the fundamentals and variations of the elimination diet. We want to recommend when and why to use an elimination diet. We're going to talk a lot about how to implement it, and then evaluate problems and practical solutions that can come up when you're doing the elimination diet. This is a cartoon about a patient telling his doctor, "What do you mean about diet? I tried a carrot once and nothing happened." You know, I remember when I decided to go to medical school, I know this is really crazy. I was worried when I got done with the process, which took about 10 years, that we wouldn't even need functional medicine anymore, that people would just realize how important diet was. And I got to tell you, I think I was living on another planet because it's worse than ever. It's worse than it used to be. And I think people in general, just that are out there fighting just to live a normal life, to me, they're not as vibrant or healthy as they used to be either. When you approach functional medicine, the beauty of it is, in addition to walking into an exam room with a pharmaceutical toolbox, you also have another toolbox. And from my paradigm as a dietitian, I would submit to you it's a nutrition toolbox. Many physicians that I've encountered along my way that are older, 70 or older, remember the day in medical schools when they had to take a rat and deprive it of folic acid and watch what happened. And so when I meet them, there's this instant connection and kind of look in this eyes like, you know, finally there's someone here that we can discuss this with. And I just want to present that to you because many people that are here, if you take a hard look into PubMed, which I'm sure that you guys do, I do it all the time. I'm spurred on to know more about zinc or different nutrients. The data's there, but the translation of it into the exam room can take decades. So this is part of the initiate phase where you perform further assessment. A lot of times you need to refer to adjunctive care to really be successful with the elimination diet. If you have a nutrition professional that you can work closely with, IFM helps educate healthcare coaches. In addition, I recommend a registered dietitian that's been educated in functional medicine, a healthcare provider, or a specialist. Usually there's someone in your neck of the woods that you get along with well, that you have a good rapport with, and that you feel really comfortable handing a patient off to. You know, it's probably radical to say this, but sometimes it's not really the initials behind your name, it's your passion, and if you have the ability to encourage or motivate. And I really look for that. I look for patient outcomes when they're meeting with different professionals, and how do they do. Years ago, when I started out as a dietitian, I thought if I regurgitated all the knowledge, just kind of bleh, then they would walk away and do fine. And I know that's silly, but that's where I was when I first started my career. And it took me a while to realize there's a real art to communicating with a patient, to connecting with them, and doing motivational interviewing, which was not taught when I was coming up the ranks, and then figuring out how to help them be successful. So it's more than just regurgitation of information. And sometimes if you're weak in that area and you can partner with someone who's great, then together you can have a good outcome. And you might actually be fabulous in that area. I feel like I'm growing in that area every day. So to initiate a therapeutic intervention, you want to consider the chronicity and severity. The key with the elimination diet is you want to reduce triggers and triggering events. And as we teach, the timeline is very important. One of the things I really appreciate about my dedicated functional medicine clinic is I can spend all the time I want, and I can take a detailed history. And it's fascinating what you find out when you take the detailed history. You can start with, their birth, were they breastfed or not, and you can pretty much just follow through every decade key antecedents and triggers that were very important in the chronicity of what's going on with them. We recommend a food-first approach, and it's very important. There's so many bioactive elements in food that we haven't even discovered yet, and there's also a synergistic ability of the components to work together. So in my opinion, food always wins. A huge issue that you're probably aware of is that our soil can be lacking in key nutrients now. I had the privilege of speaking in Birmingham to a group that were part of an NIH obesity center. And as I was going down there and preparing my talk, I decided I was going to talk about endocrine disruptors. And then the dietitian in me, I thought, I just want to talk about the soil for a while. So I threw in all these slides about nutrition, soil, zinc deficiency. And when I got down there and I was talking to them, they said, we knew all about these endocrine disruptors. We did not know that there was a 70% decrease in zinc in the soil. We didn't know that. And a lot of times I think as physicians or clinicians, but especially physicians, if we weren't taught it in our paradigm, then, and forgive me for saying this, we assume it doesn't exist, but it's up to you to dig into the literature and you'll find out that it's really true. I've spent hours in medical libraries, in medical textbooks, in nutrition aisles, on PubMed, just digging and digging for myself because I want to know what the state of nutrition is for my patients. And it's fascinating when you give a patient or a human body biochemically what they need to watch them get better. I do a lot of things in my professional life, but one thing is I'm in a hospital quite frequently. I probably diagnose B12 deficiency once a month, which I think is too much. And I'm talking less than 200. I had one guy come in, really sweet person, and he was overweight, and he had he'd been on thalidomines, and he had issues walking. He was a Walmart checker, and he said he just had proprioception issues. And I thought, I'm just going to check a B12. And it was low. So then I decided to go ahead and check the celiac labs, and they were low too. And it's just fascinating what you find if you look. So you want to assess and address optimal function, and you want to apply specific medical functional foods, vitamins, minerals, antioxidants, and nutrients. And then you want to consider a personalized maintenance plan. It's very interesting to me that vitamin D, I think, is on the map. I think most people know about vitamin D. They know how to measure it. But what I find interesting is, what about all the other nutrients that we never measure or that we're not encouraged to measure? I would submit to you, I think there's a lot left to go into for all of us as clinicians just in mainstream medicine. So this is the functional nutrition dietary interventions, and the elimination diet is in your toolkit. When you go into your toolkit online, it's under Initiate, and there you'll find all the tools that you need. So we've spent a lot of time talking in the last 2 days about why you would do an elimination diet. This is just going to be a brief overview. Number one, you want to understand if there's a connection between food and symptoms. You want to clear the plain food. One of my colleagues who has a very large functional medicine clinic in the U.S., probably one of the largest, says it helps him clear the fog and figure out where he needs to drill down. And every person who goes through his clinic does an elimination diet. You want to improve enhanced detoxification protocols, and you want to transition to a cleaner, healthier diet. So we've spent a lot of time discussing food allergy, food sensitivity, and food intolerance. It's very important that you do not say that someone is allergic to a food unless you know that they're IgE and they've had this anaphylactic response, because you don't want your patient going around telling people that, and that alarm that goes up. Do you have an EpiPen? The whole thing. So be careful. I make sure my patients, including my husband, just runs around saying, I have an allergy. I'm like, no. You have a sensitivity, you have an intolerance. And I make sure they can say that back to me, because I don't want this inflammatory response in the medical community when I actually never said that. Allergy has strong implications. So IgG reactions, in terms of how long the elimination diet, it takes, and Dr. Lucchese went through this, it takes 23 days to get your half-life for IgG deposition complexes out of your body. And you're reducing that total burden. And what I typically find in an elimination diet is my patients don't feel better day 1, day 2, day 3, day 4. Typically by day 11, they're all feeling better. There's kind of this hump they have to go through, and some of them actually feel worse the first couple of days, which is very interesting to think about and hypothesize why that's happening. And I'll run through a little bit of that. So I usually tell them, this isn't going to be fun. It's going to be one of the hardest things you ever do. This is boot camp. And I really paint this kind of grim scenario about how hard it's going to be so that when they actually do it and it's not as bad as I said, a lot of them will come back and say, it wasn't that bad. And I'm like, oh, well, good, I'm glad. Because it's really pretty hard, but it's not as hard as I like. Because I want people to be up for it and really consider what they're going to do and take the challenge. So it should be at least 3 weeks. A lot of clinicians will go 3 months. I think the art of this is to look at each patient individually and figure out what you can negotiate with them. So some of your food reactions are related to the food effect on the gut flora. Blood sugar fluctuations are not a true allergy. For instance, high glycemic index foods can trigger an insulin release, which can be very inflammatory to the body. Literature shows that a low-starch diet can actually decrease Klebsiella in the gut, which can be associated with ankylosing spondylitis. This is a study done on diagnosing and managing common food allergies, and they reviewed 1,678 studies, and only 72 were selected. And at the end of the day, the conclusion was that the evidence for the prevalence and management of food allergy is greatly limited due to the uniformity, lack of clinical diagnosis, which Dr. Lucchese also alluded to. So everybody's using different things. So with IgE, there really is a uniformity and there's inter-lab variability, but with IgG, there's not. There's so many things in food that can be interacting with the gut. That's why the elimination diet continues to be the gold standard. Prior to going to medical school, one of my patients was on disability with fibromyalgia, and she did the elimination diet, and I never saw her again. I just gave her the information and was kind of excited to see how she would do, but I never saw her again. And I got a letter about 6 months later, and it was single-spaced on this red piece of 8.5 by 11 paper, and I thought, wow, she's sending me a Christmas card. Oh, my goodness. And right in the middle it said, I'm off disability and back to work because I saw this dietitian, and I did this elimination diet. And I just stood there in my office. I thought, I think I'm going to have to go to medical school because it's pretty amazing. Just that whole systemic inflammation and what it can cause and what can happen if you just get away from the standard American diet for a little while. So this is about food allergy and IBS and the non-celiac gluten sensitivity that Dr. Lucchese talked about. And it can present with IBS-like symptoms. Extraintestinal manifestations as well can disappear on a gluten-free diet, which can be foggy mind, headache, and depression. So manifestations of food allergies can be GERD. You're probably aware of that cow's milk protein can cause a dyspepsia. A lot of my patients that have GERD, I get them off cow's milk protein and they do better. And I do kind of a two-step approach to really get them off those PPIs, which can change the pH of the gut mucosa and be problematic. Eosinophilic gastroenteritis is being diagnosed more and more commonly. Diarrhea, failure to thrive, constipation. So one of the studies found that 85% of patients with IBS reported symptoms of chronic fatigue, 71% fibromyalgia, and that there was this triad of fatigue, IBS, and musculoskeletal pain that was not explained by IgE-mediated food allergy. Patients with food allergy can also have atopy. They can have rashes. You'll see sensitivities with people. It's interesting what I've seen using the elimination diet, just fascinating what happens dermatologically with some patients with their rashes, how there can be a decrease in manifestation. Heiner syndrome, chronic serous otitis media, chronic sinusitis, systemic anaphylaxis, irritability, sleeplessness. A lot of times when you decrease the histamine release, people sleep quite a bit better. Arthropathy, nephropathy, fatigue. And there's evidence suggesting that IBS can be related to food hypersensitivity. So food antigens are actively interacting with the mucosal barrier. I was reading an article today from Nature. Was it Nature? No, it was Gastroenterology, Hepatology, March of 2019 this year. And they were talking about emulsifiers that are in food products, including carnitine and polysorbate 80, and that whole interaction with gut mucosa, changing the microbiome, changing what's actually happening, and actually inducing intestinal permeability. So again, as you dig into the literature, you're going to see these concepts more and more. I was at a neurogastromotility conference in 2006, and at that 2008, excuse me, at that conference, the editor of gastroenterology was at that time explaining to the gastroenterologists literally what intestinal permeability is. So even though it's been in the literature and it's like a snowball, as Dr. O'Brien talked about, how there was 14,000 studies and how they're increasing, it's really new. It's a new concept, although they've been talking about it for years, and it's just coming into play in mainstream medicine. So there's a proposed algorithm for IBS, and this is 2006 neurogastric motility. And what they're talking about is symptomatic reassurance and management. And if the symptoms are controlled, great. But if not, you might want to test IgG4, you might want to test IgE, you might want to do skin prick testing. And as discussed earlier, in the literature, there's no concordance with IgE and what's going on in the GI tract. Patients will tell you that's not what I think is happening here. There is something called a COLAP, which is never used. It's a colonoscopic antigen propagation test where they actually inject a wheel into the GI tract, or excuse me, inject a foodstuff, and they look to see if there's a wheel. And there is concordance with that. And at the end of the day, if that doesn't work, you might want to consider a hypoallergenic diet. So the mucosal immune cell activation is attributed to exogenous factors, food antigens, the microbiome, endogenous chemical irritants, colorings, additives, all the things that we're doing to food, bile salts. So when you put someone on an elimination diet, what you want to say to them is this needs to be real and clean. One of my colleagues talks about on a label, if there's more than 5 ingredients, stay away from it. So you're teaching that person to go to the label and to look at all those crazy words and to walk away from that for a while and just see what happens. So the gastric epithelium is the first significant barrier between your body and the potentially toxic material in the lumen. Dr. O'Brien talked about that donut, which I thought was a great example, where he stretched it out. I talk about a garden hose. I also discuss with patients that I say, I want you to imagine that you're walking into a studio apartment and the whole floor is the surface of your GI tract. Now let's imagine that there's shag carpet there and that those little villi are where all your nutrition. And now what we're going to do, we're going to put a coating over that shag carpet. That's your mucinous layer. And then we're going to talk about what can happen over the years. And then we're going to poke holes in that, and we're going to talk about intestinal permeability. Those are the kind of word pictures that engage people and draw them in. And I'm sure that many of you out there have your own. How many people in this room have done an elimination diet themselves? Okay, great. So if you haven't, I encourage you to do them before you ever put a patient on one. I try to do every elimination diet that I've ever been on. I actually follow all the recipes and I do it exactly the way I'm supposed to, so I really know what I'm handing off to other people. I like ours. I think it's really good. There's a lot out there that you can find that are also very good. Ours is really user-friendly. In my office, I have multiple copies printed of this as I do the cardiometabolic plan and other plans. So nutrients affect the gastric barrier continuously. Alcohol is big. You know, alcohol can deplete your GI tract of glutathione. It can decrease the mucinous layer. We teach people it's okay to have 2 to 4 alcoholic drinks a week, and then people translate that into 2 to 4 a day. Most of my patients, when I ask them to give up wine, they get a horrified look on their face. But most of them, when they add it back in, feel terrible. And I've had many patients that come see me that have arthritis. They're actually positive for anti-CCP. They are on their way to full-blown rheumatoid. And they're understanding that they need to get a hold of this. The people that seek me out in my functional clinic they've read a lot, so by the time they come see me, they want this. It's a whole different paradigm. I've done primary care. When you're in a primary care situation and you're the first to present it to a patient, that's a whole different way of negotiation. But in my functional medicine clinic, it's very interesting because by then people have read enough that they have buy-in. In the primary care days, I would ask patients to read about it and to come back and we would talk about it because I wanted to make sure that they knew a little bit about it before we went forward. Dietary lectins in disease. I think that you're going to see more and more of this. I'm surprised. When I first read about this in the literature, a friend of mine gave me a textbook from England, and there was a chapter in it that had 265 references. And as I read about lectins, which are carbohydrate binding proteins and what they can do, I thought, wow, this is really important. There's not a lot of ways that you can measure this. There's a couple labs that I know of that are thinking about it. There are people that are very concerned about its inflammatory effects on cardiovascular endothelium. There's physicians out there that are beginning to tailor whole programs around lectins and staying away from them. So it's a fascinating science to think about. And wheat lectins can be very problematic. So I think that we might see more literature regarding that in the future. Histamine and histamine intolerance, some people genetically do not make diamine oxidase, which is the way that you break down histamine. And you can actually get that tested on a genetic panel. You can also stay away from high histamine foods and try the supplement too. A lot of times with my patients, part of my negotiation is, how am I going to use precious dollars? Where am I going to get the most bang for my buck? I mean, not everybody has unlimited funds. So a lot of times in my head, I'm trying to figure out, how am I going to spend somebody's money to get the information that I need? And I usually always start with the elimination diet. One of my patients came to see me, and she'd had a headache every day, and she was on hydrocodone for years, and she was getting ready to go to Johns Hopkins for migraine type clinicians. And it was really interesting. I put her on the elimination diet. She came back in 3 weeks, completely headache free. And she added back, I think it was dairy that was causing the problem. And I know that you know this, but it's so important when you're talking to a patient that you're not just looking at the GI manifestations for the elimination diet. I used to do that years ago. Honestly, you want to look at arthropathy, fatigue, headache, and most people that have been doing this a while ask everybody to do this because there's a lot of benefit from just getting on a clean diet for a while and seeing how someone feels. Histamine is involved in all of these things: neurotransmitter release, vasodilatation, tachycardia, lots of things. So histamine intolerance, the foods that are the highest are aged cheese, sauerkraut, wine, processed meats, older foods, citrus. And then certain medications can make it worse: analgesics and narcotics. Vitamin C and B6 can help, and there are supplements out there if you look for them.